Well, it's a real honor and a privilege for me to be here in front of patients. This is why I went into medicine. That was a great talk. So Diego, great to see you again.
Thank you.
I will say I took a bunch of notes. I haven't seen him in years. Tell Alan Levy hello and his family at Miami. I'm proud to be part of this panel because it really is an internationally known group of experts in the field. I really want to just add on a few comments to Diego's really terrific talk. First, I really wanted to talk about the potential for surgery and give you all hope beyond the medicines and the side effects, because I really do think the future is quite bright. A few years ago, I see my wife in the back, who's a physician with me at Mayo, and we've been there for 25 years. We used to go with our kids when they were smaller to the Caribbean, and one year we came back and there was an awfully long line in Atlanta clearing customs. And you all have been through long lines where they have that S and you're following someone and you're trying to gauge how long it's going to take, and you have another flight and the kids are crying. And I remember seeing someone with severe cervical dystonia, and they were locked in rotational torticollis, like some of you may have. And I was watching this person try to meander through the line. Going right was okay, going left was impossible. You all can sympathize and empathize with what I'm describing. And I told my wife, I said, I felt like dropping a business card in front of that person or give it to that, but obviously I'm not going to solicit patients. But I wanted to say something like, I can help you. So that's sort of the story that motivates me every day. In follow-up to Diego's talk, I wanted to give some answers. He asked the audience how many people have had symptoms or misdiagnosed after 10 years. Let me talk about one patient I shared. The oldest patient I operated on, he was about 84. He had had cervical dystonia since he was 18. He was with his wife, and they were married for almost 65 years. And his wife told me she had never seen him straight. And she pulled out a black and white marriage photograph of him getting married 65 years earlier, where he had some dystonia, and then that evolved, and I finally did surgery on him, and he did very well, and we straightened him out 65 years later. So the misdiagnosis is a problem. The other just comment that he was talking about was sensory cues, and we all have to deal with work and society, not just the pain. But one of my patients was a judge. Diego was talking about a lawyer and the problems about doing that as your day job and thinking about the other people seeing you. And I'm sure some people have seen My Cousin Vinny, the movie, and the lawyer had a tic or some movement disorder, and they were kind of mocking that person. And I had a judge, and he could only position himself like this, and he's trying to conduct the court. You can all realize sort of the mental anguish in that while you're trying to be professional. His sensory cue was using his mouth. When he ate, his symptoms went away. So I asked him, obviously you can't eat while you're presiding, but I told him, I said, try bubble gum. And he put bubble gum in, and it was able to actually improve things until we operated on. So sensory cues are part of the problem and the solution. Let's see. Okay, so here are my objectives. What torticollis is, you heard. Why surgery may be needed. Learn about available options and goals. know what to expect before, during, and after surgery, and to understand the long-term care and recovery. You know, I think Diego laid a beautiful framework for me, and I'm going to leave the framework for the neurologist to follow me. So we've heard about spasmodic torticollis and the definitions and the focal dystonia. It's really not very well understood, and we also talked a little bit about demographics and epidemiology. And I would just say my father, who was a physician, always told me things are rare, but if you're the one, it's 100%. And I've always remembered that. What are the symptoms? So this is what I want to talk about because you all know them or know people who have it, and that's why you're here. And I think obviously, you know, we're all thinking about the deviation from the seesaw muscles that are over pulling. And I think Diego did a nice job, especially talking about the different vectors, the turning your head different ways. So either rotation to the right or the left, so you're going to the side or down to the shoulder, or front or back. And I remember having a patient who wasn't a secondary dystonia like Diego had talked about from a medication where they went into retrocollis. This patient, before he had seen me, broke his hip. We had to delay surgery because he didn't see something on the floor because his head was up. This is the quality of life that we're all thinking about. Many of my patients struggle with driving a car. And they ask me, can I drive a car? And you look at their head and it's contorted. The first thing I say is, do you have a license? But I have all sorts of patients doing clever sensory cues with their hand on the window and keeping their head and whatever. But is it safe? I can't judge that, but we can all empathize with the struggles that people have with that. But I think the problem with the activities of daily life and the provocations of eating and walking and things like that, and we were even talking about, you know, one of the things that can improve the dystonia wasn't on the slide, and that's alcohol. And I've seen several people who said that they got so much relief that they became addicted. I'm not advocating that either. But I want to talk about function, pain, and form. So the deformity. The deformity is a problem. It's a problem because it induces pain. It creates a problem with driving. It creates the problem for the lawyer. It creates the problem for the judge. It becomes a problem in society. It also causes the neck pain. And the neck pain can be for different reasons. But if you think about it, when I even talk to patients and I put my head in a position like theirs, I get neck pain just for my 1 minute illustration because everything is tightening up. And then on the good side, I'm overcompensating. And on the bad side, my muscle's always on. And then you think about the degenerative changes that Diego talked about. There are so many reasons why this is painful. I've had some patients who've had headaches, and that's a whole different aspect of dystonia is the nerves either at the muscle level or some of the occipital nerves can also be responsible for occipital neuralgia. And I'll talk about that in a minute. And then, of course, cosmetics, aesthetics. This is part of life. You stand out, people stare, just like Cousin Vinny. Sensory cues are helpful because it helps you adapt to all of these things. So the evaluation always starts with the patient and then going to their primary care physician, but we talked about the delays. So it takes delays, takes a long time. We heard about it this morning with your informal poll about how long it took for you to get diagnosed and to get to a neurologist. And I would hate to say that many of the neurologists aren't well schooled in this. You have to get to an expert like some of the ones you're seeing because some of them also don't see a lot of patients with dystonia. They may see Parkinson's and they may see other problems, but they may not have seen what you or your family members have. And then if you think about the delay to the neurologist, the delay is even magnified because many of the first-line neurologists don't know that there are other options. So the delays are rampant. And whether it's a lack of a diagnosis, we just don't know. Misdiagnosis, it'll get better, you have a cold, you have whatever. There's a diagnosis, but they're not aware of all of the treatment options. Or the diagnosis is there, but they're not aware of who does the targeted treatments, whether it's Botox or surgery. There are some people who are just injecting in their office some muscles, but they're doing it just like people get Botox for cosmetic reasons or headaches. It's not really scientific. They're not the cutting edge of what needs to be done for dystonia. So why is that? Well, it's a relatively rare condition. And if you're not at a center that sees a lot of it, your physicians, your surgeons may not know a lot about it. And then the targeted muscles and the dosages, and we were just talking about the different brands. Do you really think that every neurologist who's a generalist knows about the new agents and how to fight City Hall to get insurance to pay for this? Or that there are a few doctors, surgeons who are doing surgery for this? And the surgery is not widely performed. There are very few people who do selective denervation now. And I say that respectfully. It's not that this is any more difficult than lots of things I do as a neurosurgeon. It's just, it's rare. And I was very fortunate and am fortunate to be at a center where this has a rich history. So I learned it from someone else. It was passed down to me. Now I will say, of the surgeries I do, this is the most gratifying, most enjoyable surgery I do, because I can change someone's life. End stop. So whether it's the judge or the 83-year-old person whose wife never saw him straight, I can change people's lives. Now, the differential diagnosis of spasmodic dystonia is broad. I get lots of people who really don't have it. They have neck stiffness, they slept wrong, they have spasm, and their doctor's telling them it's this, but it really isn't. Ryeneck, congenital torticollis, is a different entity. I can fix that too, but it's not a primary neurologic problem, as best we know. And those are the ones that babies are born with, and occasionally somebody else have sequela of a kind of a neck that's a little bit off. It's because they weren't treated at birth for what was a birth-related injury. And then there are people with psychological forms of this. But those people don't respond to the nerve-type operations or even Botox. So the congenital form, which is very treatable, it's an easy operation for me, doesn't respond to Botox. But there's a simple mechanical operation that I can do to help them. So we heard all about the options, and we heard a little bit about the outcomes, and we heard about the side effects, and we heard about the pain, and we heard about the insurance issues with the Botox. I will say I've never seen a patient make it 6 months with Botox, with an injection. So he was saying some of the newer agents last 6 months. Now, I have a selective bias. The patients I see haven't responded, so that's not a fair comment. But I'm allowed to have my opinion based on my experience. So if someone comes to me, I always see them with a specialized neurologist. If I would have someone, an expert, like some of the people you're going to hear on my team, yes, absolutely. Because the misdiagnoses, even in my practice, of people being referred is very high. I see them with an expert in movement disorders, who's very well trained and qualified to do dystonia and focal forms of it. Now, different than many institutions, we do special needle type EMGs where we're not looking for neuropathy per se, like with diabetes or other problems, but we're listening to the muscles to actually map which ones are the very bad ones and which ones are the mild ones. Because occasionally, somebody looks a certain way and they have a pattern of what muscles are overpulling, and to our surprise, certain muscles may or may not be overactive. So for me to operate on muscles that are not the bad ones is a waste of my time, your time, and an added risk that's unnecessary. So we're trying to target the bad muscles, nerves. And then I'll see the patient with them, we'll deliberate, and most of the time at our institution, the operation I'm going to talk about, so at the Mayo Clinic, we primarily do this operation that I'm going to talk to you about on the end organ, like the Botox, not the brain where the problem is theoretically localized. Even the people with the brain, you're still having sort of the dystonia. You're modulating it, you're changing it, you're lesioning it. With this, we're dealing with the end organ. And I'll talk to you about why we do that. Occasionally, there'll be patients who have a broader, more generalized dystonia or a tremor that I then refer for the deep brain stimulation. But they come to me or to the neurologist primarily for this peripheral nerve problem. So why might surgery be recommended? Well, obviously a lack of improvement with therapy. The therapy is not a cure. We heard all about the problems, even with people who respond to Botox. You heard it. This is what Diego does every day. And in his slides, he was talking about the 2 months out of every year that it doesn't work. Not to mention the side effects, the costs, the injections, the pain, and the fact that people get tolerant or resistant. And it doesn't cure, and people get partial responses. So what I'm talking about is a longer acting treatment. Even with partial improvement, people's pain often doesn't get better. So we're always looking for a better mousetrap. When is the right time? Well, it's like anything else. We all sort of have to make our decisions about what it is. I tell patients I hate dentists. So a few years ago, I chipped a tooth. I thought immediately I was going to need emergent root canal. I know nothing about teeth, but I hate dentists. My dentist knows it. He's a very nice man. And every time I see him, I tell him how much I hate seeing him. So last time I saw him, he goes, and I hate seeing you too. So we both felt better. So I go in, it happened on a Saturday. I was driving down from Minneapolis and I felt that chip, and it didn't hurt, it just felt really weird. It was one of the back teeth in my tongue would play with it. It didn't hurt, but I felt that chip. I call up the dentist, I get a service on a Saturday. They said, well, if you're not having pain, we can see you on Monday. I thought, okay, isn't that weird? I need emergent something, and I can wait till Monday. So I went Monday, and I see my dentist, and he says, what's wrong? And I tell him, and he looks at my tooth, and he goes, oh, you're very lucky. He said, it doesn't hurt? I said, not a bit. It feels weird. He goes, oh, two things will happen. One is you'll get used to it. The other is you won't get used to it. All right, 50-50 chance. He goes, most people get used to it. He said, and you're very lucky because where it's chipped, you're not at increased risk for infection. He said, and no one can see it. It's one of those teeth, whatever. And I looked at him, I said, but it's driving me crazy. Well, why is it driving you crazy? I said, because I'm playing with it with my tongue. It's like when, you saw there's a Saturday Night Live or something where it's don't look at the mole. Don't look, you have to look. So I'm playing with my tooth. with my tongue. And it doesn't hurt. I feel the little glacial edge. And he says, you'll get used to it. You're a smart guy. You're a neurosurgeon. Anyway, I said, well, what happens if I don't get used to it, right? Fair question as a patient. He goes, well, we can fix it. How do you fix it? Oh, you know, I'll have to put you to sleep and do this and that. And I said, oh no, I'm getting better. And you know how much I hate dentists. And he said, okay, see you in 6 months for your checkup. For 3 weeks, I'm playing with that tooth, doesn't hurt, everything, it's bothering me. I'm looking at the mole. Don't look. I'm playing with my tooth, it's driving me crazy. I call him up 3 weeks later. I said, please fix my tooth. He said, wait, you're the one who hates dentists. I said, I hate this tooth more. He fixed the tooth, and it was one of the better decisions I've made in life. All right? So when was the right time? He couldn't tell me to fix it. My brain just didn't relearn it. And I wanted to get on with life. So when is the right time for surgery? Well, you or your loved one is the one suffering. And I'm going to talk to you about what I could do. So as a surgeon, I'm trained to do this procedure, the selective denervation, the nerves and the muscles. And then there is a very good option, deep brain stimulation. I don't perform it now, as I'm very subspecialized, but I have a colleague who just does it. And he creates a lesion in the brain where the problem theoretically occurs. The advantage of what I do versus the DBS is that historically, denervation's been around for 150 years. Deep brain stimulation is the newer procedure. It's been around for about 50, but for dystonia, pretty much less. It's gaining popularity for lots of reasons. It's a new toy. People are using deep brain stimulation, and I don't mean a toy. This is a wonderful toy. I mean, deep brain stimulation is doing great things. It's going to work for not only movement disorders, but now people are doing it for addictions and psychological, psychiatric illnesses. I mean, the future's very bright. Terrific. It's still an operation in the brain. So, many of my patients don't want brain surgery. I wouldn't either if there's a different choice. So to me, I think it's safer because deep brain stimulation, while it can work and does often work, there are catastrophic complications. Even a small bleed in a bad spot is a bad problem. My operation, I believe, and I've shown, is safer, at least in my hands. And you're not operating on the brain. And you can always add the deep brain stimulation if mine doesn't work. So I'm not taking anything away from it. I'm just saying at our institution, this is what we have done. And we've done it for a long time. And I think we'll continue to do it, even based on other people. The disadvantage of the operation I'm going to talk about is that few surgeons do it. And again, it's not that it's any harder, it's they didn't learn it. They didn't see it. People didn't do it. But it's not harder than the things that we do every day. I do think that in the end, deep brain stimulation is an important trend and probably is a little bit less painful at the start. But this is a short-term investment. I didn't want the filling in my tooth. I was willing to go back, even though I hate dentists, because it was the longer-term vision that I'm happy about today. So I'm giving you a 10-year follow-up. I'm very happy. And he's a very nice guy. All right. So there are a bunch of nerves on the left that I target. These are the bad apples. So to patients, I talk about a seesaw. And there's someone who's a little heavier on one side in the park, and there's someone who's much lighter. Whose side is going to go down on the seesaw? And that's what's happening with the tonic phase of cervical dystonia. So I'm trying to equalize, put the other person on a crash diet. So I'm targeting just like the Botox, but surgically striking it. So on the left are the nerves that I usually do, and on the right, some of the muscles that I target, and depending on the patient and the EMG findings, I come up with a formula that works. Now the goals, again, the first thing is expectations. I can't cure dystonia. It's the first thing I say. I even call that a complication. I'm not going to cure this. I'm here to help you. And about 80% of patients I can help. Those are good odds. Without the injections every 2-3 months, and without the side effects, and without the this, and without insurance. Now, I have problems with insurance companies too. They call, even DBS, they call any surgery experimental. But who am I getting on the phone? I'm getting a general physician whose insurance company just stamps a no. And whether it's for the cancer drugs that we've heard of or whatever we've heard recently in the news, there are issues with insurance companies. They want to say no. It doesn't take a lot for me to convince the person on the phone, and I do a direct with the doctor, and about once a year I have to fight it, and I've never lost. 25 years, I've never lost that one. At the Mayo Clinic, chairman of the department, here are some papers, and they say, oh, I never knew. Or they didn't want to know, whichever one, but I'll leave that. But I'm able to advocate for my patients, and they will pay for this surgery. Now the goals, I'm here to improve the head position, I'm here to improve the pain, I'm here to improve the cosmetic issues, which people don't voluntarily bring up. But I can see it. The tremor, the dystonic tremor that you saw and you heard about is less predictable. So with people with a very bad tremor, that's not a reaction to fighting the head position. There's a difference. One tremor, many people have. If my head were turned to another way, I'd be fighting it all day also. That's different. That's the brain voluntarily trying to get back to the center of the world. The world is here. The world isn't there, and the world doesn't want the sensory cues. So some people have a tremor reacting, compensating, which is different than the dystonic one that you saw the video in the first lecture. But I'm also here to prevent long-term issues, including the bad arthritis, because we can show and prove that some of that gets better if your head is straighter. It makes perfect sense. Now, there are risks of surgery. I tell people there's risks of everything. Risks of my coming out here to speak to you on a plane. Risks of my driving home to work, from work, hitting a deer. I still come to work. And I tell people if I were afraid of going to work with deer, I would stay home all day and do Zoom calls. Until we had a neighbor where the deer saw their reflection in their mirrored house, and the deer burst through their living room windows. Blood everywhere, and the house was in disarray, etc. So you're not safe anywhere in Minnesota with deer. The point is that there are risks. But I would say that the risks of what I do are quite rare and are relatively minor. And I say it respectfully. I hate complications. I treat everyone like family. I mean, I want patients to do well. That's why I'm here. That's why I went into medicine. That's why I want my kids to be physicians. Wound infections, those are rare, even with bigger incisions. People get some numbness because, as we were talking about, one of the cause of this is a nerve problem. Nerves tend to do motor and sensory function. So I'm trying to kill the motor. But on the way, these mixed nerves can also cause some numbness. So people end up with some numbness on the scalp. But they don't have the big risks of the stroke and things of that sort that can happen There is a small risk, and the small risk is because we do this in a seated position where you can get air, and air can go to the brain. Very uncommon, and in fact, we popularized sitting operations at Mayo. We've done it for many years and have an incredibly small risk. There is an artery, the vertebral artery, which is near where I operate, but we've redesigned the operation so I'm further away from the vertebral artery, and I did that specifically for safety reasons. So the operation that I do on nerves and muscles is away from the big artery and really can give you a belt and suspenders way of getting the effect that you want on that end organ. But again, I can't cure it, and I can't improve everyone. And I've been very interested. I'm very selective in the patients I do. So if I offer someone an operation, I believe in my heart they're going to get better. The nice thing about being at Mayo is I'm salaried. It's actually more work for me to operate. So if I'm operating on you, this is a two-way agreement. I think I can help you. I want you to do well, and I'm invested in you like you're invested in me. And that's why I stay at Mayo. There's no incentive. I'm not going on vacation with my money. I mean, I'm salaried. I love what I do, and this is my favorite operation. I'll make a full circle with this statement. I can change lives. Now, the one thing my wife asked me, she said, honey, you do all this stuff on the one side and the seesaw. Can you overcorrect? Can you get someone and they fall down? And the answer is no. So unlike the Botox, where you can have temporary side effects where your head drops and stuff, I have never seen it in the hundreds of patients I've treated. Never. And I always say I need to even be more aggressive, because as aggressive as I am at surgery, at trying to get the muscles, everything is dystonic. The brain wants to go a certain direction. And as hard as I work and as much as I do, I'm not stronger than your brain. So what to expect before surgery, pre-op evaluations, meeting the team, having me kind of figure out which muscles, which nerves I want to target, kind of getting ready for surgery. The day of surgery, you would come in fasting. You'd meet the team, say hello, mark you, the usual things, and then you'd have the surgery. Surgery's done, you're asleep, I'm awake. A little bit, it's unusual because you're seated, so we actually have to put some pins in the skull. So behind your hairline we put, and that's the way you are rested. And your head is fixed and my hands are extended. Antibiotics, surgery lasts about 5 hours. A lot of the surgery time is actually positioning patients because they're asleep, and then they're sitting. It takes a while to kind of get that so it's safe. Post-operatively, most patients are in the hospital 2-3 days. It actually has sped up. And when I look at my predecessor's reports, his length of stays were longer. He had deaths, not many, but a handful. There were some serious complications. So the evolution of life keeps improving. It's not that I'm kicking patients out. Everything's getting better. Pain management, the surgery is getting shorter. We're getting more targeted. Things are better. Now, what to expect? This is a painful operation for the first few days. There's no way to sugarcoat it. And I tell people, you're not going to like me the first day. And people with a bigger neck, it's deeper, it's harder. I drool when the patient has a thin neck. You know, I'm sitting there saying, you really are helping me tomorrow. And I look in the audience and I see thinner ones and thicker ones. And again, I'm from Minnesota, Iowa area, so there are a lot of jokes about Iowans, no disrespect. But that's just This is what we hear in our neighborhood. But the point is that the thicker necks are more work, and it's painful. And it's harder, and the surgery takes longer. Bottom line is that if you're straight after surgery, that is an outstanding predictor. And I go in there and the patient's saying, gee, I'm having terrible pain, and I go, but here's a picture on my phone. Look how straight you are now compared to 5 hours ago. We'll treat you for the pain. We'll get you through the first day or two. And the pain is rough for the first day. You're on medicines and PCAs and narcotics and all of that, but the point is in most cases, it's temporary and it's worth it. And the spouse is usually the biggest cheerleader. Honey, look how straight you are. Have you seen it? No, my neck hurts. But you're so straight. We mobilize the first day. We put a surgical drain in to collect any extra blood, and that comes out on the second day, and people usually go home. They've seen the therapist on the first day. I tell people I give them the tools to get better, and now it's up to them. Because therapy is important for people who have been turning for 65 years, like my patient I described. You can understand where his brain doesn't know where the center of the world is. So mirror exercises are really important. Recovery process is really quite good. So patients go home, usually they stay in town for another day or so, but almost all my patients are on an airplane. They're able to go home and have their lives. I tell people no work for 6 weeks because we're trying to create an environment like your first hour where you're stretching and you're thinking good thoughts and you're getting into a good headspace, where stress comes at work. Work is stressful. We're trying to avoid stress so you can not only create wellness, but you can concentrate on well-being and getting better. A lot of the people are compulsive people, and they say, well, can I work from home? I try to talk them out of it. I really want them to have an environment where they're protected. Activity, they're able to do whatever they want, but they have to think about therapy, and they need some time to get well. Typically, patients are off medication, pain medicines by the first week, so it's very unusual for people, very unusual, to be on it longer. Home therapy is important, but it's done by the patient. They're not now seeing a therapist after a few visits. And then the follow-ups, if patients are doing well, now can be virtual. One of the nice things about COVID is that technology has really changed what we do. So for people out of town, I can see them on their own time without the expense of coming to visit. Now, long-term, the outcomes really are quite good and they're immediate. There's no 1 or 2 weeks, and it's usually not temporary. We have long-term follow-up, we have years follow-up. Patients do well. But again, not everyone. And if it's 80% improve, and I'll show you pictures, it's not cure. And at the end of the day, people still will feel fatigue. And if your brain feels fatigue, your brain is always saying, go right. Go right. During the day, you're able to fight it better. It's like people who wear foot braces. People who have a little bit of a foot drop. I tell them don't walk in the Mall of America and shop. That's not, the 40,000 steps that they would do isn't great for a foot drop. You might be able to get around life and, walking in where you need to, but don't test yourself and do a 20-mile hike. And again, when you're stressed, you're going to tend to revert to where you were. And if you're not doing well, I'm the first one to want to see you because I have other things up my sleeve now, including going back to Botox. Because if I've killed, euphemistically, the bad actors, and now there are fewer bad actors because I've killed them or taken the muscles and divided them, then my neurology colleagues can kind of concentrate on the remaining bad actors that I either couldn't get at or didn't. Or there are even secondary surgeries that I can do. When to call the team, I think when there's a problem, which is unusual. because I've already arranged my follow-up. By the time people leave the hospital, the emergent problems have already gone away, time-wise. If there were a problem, I would have known it. So let me go over a history, and this may remind you of someone. 41-year-old man comes in with a 1.5 year history of spontaneous onset of his head turning to the right. He didn't cause it. A virus didn't cause it. He didn't get it from his father. Just out of the blue, this happened. Initially, he was able to correct his head. Over time, the symptoms became worse. He felt the involuntary pulling sensation turning to the right, which then became painful and uncomfortable. He controls it with various sensory cues. He didn't respond to Botox or a variant. He went through several rounds without benefit. And the EMG that we did showed that where his muscles were overacting are the usual targets, so I offered him surgery. Here he is at rest. Think about making a left-hand turn driving a car. Think about walking in the S at the customs. He's a young guy during COVID. This is his resting position. Hard, painful, sad, but there's hope. So here are patient questions, and you can ask me other ones, and even after the meeting, I'm happy to answer emails or whatever. Are surgical results related to duration of symptoms? And the answer is no. I had the 70-year history with my person getting married. Will I need more surgery? Maybe. Rare. Will pulling come back? Occasionally, but not real common. Why might Botox work after surgery but not before? Because I've killed some of the bad ones. Fewer targets. How often do patients need Botox after surgery? Not often, but if it helps, anything we can do to make people better. So here's the surgery. Person would be sitting. These are sort of the right-sided target muscles. You may know some of the names. Our neurologists certainly know that these are some of the ones that they're targeting. And these are deep muscles. And I would talk to the residents. I said, you know, we don't really learn about it because in neurosurgery, you go straight to bone. And now instead of going straight to bone, the spine, to do the decompression, the fusion, we're now dealing with an interval between the third and fourth muscle, and that's where the nerves live. So if you put it together, it's actually a three-dimensional puzzle. And it's not any more difficult than the typical brain surgery, but that third and fourth level, like the chapters of a book, are where these important nerves that I can operate on. These are not the ones that are going to your biceps or shoulder. And that's what I can target to help denervate. At the top, this is where the vertebral artery lives. So the vertebral artery is actually at the top, and I leave a muscle bridge, so I'm away from it. This is C2, and that's one of the ones that actually gives headaches in some people. So I've had patients who've gotten their headaches improved for unknown reasons, but it's not unknown. C2 can give occipital headaches. The other muscle that I often go after is this sternomastoid in the front. Many of you know that, and here's the surgery. I look for a little skin nerve, and then I make a window, and then I target one of the nerves, and I leave the other one, which is the important one when you were stretching this morning, that you want. People will say, yes, but my trapezius is overacting. Can you just cut that? And the answer is no. That's the one I'm leaving, because if I cut the part that goes to your trapezius, your shoulder won't go up. You won't be able to do the nice stretches that you did this morning. Now, I credit people appropriately. I think Bertrand really pioneered this. He was a neurosurgeon at Montreal Neurologic Institute 40 years ago. He popularized the procedure that has his name, but it's been done for 150 years. Bertrand wasn't the first. He created a certain sort of avenue for us to sort of improve upon. Hans-Peter Richter is in Germany. He popularized it in Europe. And then, let me go back. My teacher was Dr. Davis, who did it at Mayo Clinic for 40 years before, and he was wonderful and very patiently taught me sort of this somewhat unusual operation. And then I've modified the Bertrand procedure for certain reasons. Now, you should never modify a procedure and say it's a modified procedure, because that person said if I wanted to modify it, I would have. It's a different procedure. But I obviously don't want my name attached. This is his procedure. I've made a few nuances. He did a great job. So his procedure, he did certain things. I want to talk about what I have done. So the C1 is where the wrists are. I've gotten rid of that. I take out the muscle that C1 innervates, because then I can do it faster, safer. And I take out a muscle that you don't need. I've also found some other nerves that are deeper that really aren't in the textbooks. They say everything in life is in a textbook. These nerves, if they're in a textbook, they're small, and it might be in another language that no one has ever thought about. So this is a belt and suspender approach. We target nerves and muscles, and I think it works. So here's a different example. That first one was turning right. This one is turning severely left. So, same operation, but different sides, like flipping a coin. That one was going right, so I did right in the back and left in the front. And now I'm going to do the opposite. There are the nerves that we're targeting, and it's just like a book, same pictures, but different sides. Cutting the nerves, and then the opposite sternal-mastoid. Cutting the muscle, cutting the nerve, and here she is. Changed her life. So this was the cover of our medical journal. If you publish something, then put your money where it is and put it out there for people to criticize you. But the point is that just like turning the pages of a book, it's a very easy way for people and other surgeons to learn this technique. The anatomy is the anatomy. People went straight to bone. I tell people, right before you get to bone, make a left. And that's that interval between the third and fourth chapter. And then I was sitting there because I teach my residents and I was using my hand, and I said, oh, let's make that into a picture, because picture is worth 1,000 words. So the indications, I think, are these types of torticollis: the rotational, the left to the right, the lateral collis, the retrocollis. My operation does not do the anticollis. Now, the anticollis, where your head is drooped, first of all, you want to make sure it's not a neurologic problem from a head drop from a muscle. But there are dystonias not from medicines that are from that. This operation doesn't do those muscles. There may be in the future some muscles that I can do, but it would be a different operation. It doesn't the tremor and the non-neurologic causes. The outcome's about 80% for head position, for pain, improvements usually durable, and a very low complication rate. If you are pulled in one direction, it's better. If you've had a response to Botox, usually that's better. But not always. Everyone doesn't read the book. So we are looking now at, this is under review, 163 of our patients, so big volume, not rare. I just wanted to end with a revision. Occasionally people are good, but is good good enough? And the answer is good is good. Everyone wants to be better. So here's a young woman. A is where she started. Wow, hard for her to drive the car too. B is where we got. Pretty darn good, right? Not good enough. Her sternomastoid stump, which was cut, and even the nerve supply was denervated, there still was bulk there, and this was creating her brain to sort of understand this. So I want to show you this, and I could show you outcomes. That's not really important. But here's someone this week. This is 1 week data. Okay, This is where we started. Everyone could see how broad that sternomastoid is on the right. This is where she lives. This is where I got her pretty good. But let me just show you the problem, because Diego talked about it, and I'm fully transparent with data, because if we're not honest with each other, then I can sell you a farm, and I'm not interested in that. Here she is on the treadmill. So just watch her. Much better than where she was, but here's her sensory cue. And there's her head position. Involuntary, not great. Better. So we just took out the stump of the muscle. It's a minor thing. This takes me 45 minutes, make a small little cut, and there she is. Okay, now I have to get her back on the treadmill. But immediately there's some improvement. Now I would just say, we mentioned a little bit about spasticity. My job is to teach other neurosurgeons. They're learning about DBS. There are benefits, there are disadvantages. DBS isn't everyone's first choice. Mine's a good operation. Now I just wanted to end. This is where I started, okay? My dad was a doctor. I love the way he helped people. This is why I'm here today on holiday, okay? This is my dad. He was an anatomist and a surgeon. And he learned, his teacher was an anatomist. So I talked about anatomy. I learned it from my father. A few years ago, my wife, who's in the back, I mentioned, we were interested in a tumor that really has been a hobby of mine. And we figured out sort of that the theory that I proposed was accurate by looking at anatomical specimens. Here and there we were. But the point is that it was all anatomy with this theory. Anatomy taught me how to do this operation that I'm talking about now. There's better anatomy that I need to learn to take it to the next level. But here, it's all about 6 degrees of separation. So when I was interested in that specimen that we went to Paris to look at, there's me. My father learned from Dr. Kaplan. He wrote that book. Dr. Kaplan was a big anatomist. He traded us to Duchenne. But the point is that pickle jar from 1800, I linked through my father 4 ways, all via anatomy. That's what I'm talking to you about. And whether it's anatomy of the peripheral nerve or anatomy of the brain, anatomy is the key. I'm fortunate this is one of the journals that I'm editor of, and there we kind of published the fact that this person who did the pickle jar specimen was actually one of the people who put together that skeleton that now has almost become viral. He wasn't getting credit, and serendipitously, the same person that I was interested in was a really famous anatomist. So the takeaway is you have a really good version today of sort of seeing the full spectrum of what's available. I'm not selling it any more than I'm selling anything else, which is medicine, science, data. This is a good option. There are other good options, and then you have to individualize. This is my group. Very proud to work at Mayo. It's a great place. I have wonderful partners, including neurologists who aren't shown in this picture. We're all surgeons here. But one of my colleagues there, where is he? Somewhere there, maybe he didn't show up, does my DBS with me at the Mayo Clinic. Thank you very much.